Hi, everyone. Thanks for joining me. I'm Dr. Eric Westman, and I'm an associate professor of medicine at Duke University. And I'm going to talk about cholesterol tonight and statins. And should you take a statin medication for a high cholesterol? So thank you for joining. If you haven't followed the work that we've done at Adapt Your Life Academy or that I've done at Duke University for the last 25 years, let me bring you up to speed. In 1998, two of my patients did what was the Atkins diet. And I learned through going to doctors' offices that there was possibly a legitimate way to fix obesity, because two of my patients had this fix their obesity. This is 1998. So one thing led to another, and I decided to start some research. So Dr. Jeff Vollick, a PhD and expert in exercise and diet, also nutrition, at the University of Connecticut at the time. I'm still at Duke. Jeff has moved to Ohio State and Ohio State University, but we both ended up wanting to study the low carb or keto, low carb induction, Atkins induction. I get into all that language. It's pretty much the same thing of reducing the carbohydrates. Back then, and even today, the major sticking point is what happens to the cholesterol. Oh my goodness. Back then it was, so my initial response, like doctors today or healthcare providers today, is what's going to happen to the cholesterol. And today I still get people coming in, doctors telling them you need to worry about, don't do that funny diet because your cholesterol will go up. Well, so I'm seeing two people in my clinic back in 1998, and I asked around to my colleagues at the time, and they said, no, don't recommend the Atkins diet or low carb diet or keto diet as it's called today, because the cholesterol will go up. So I went back naively to my patient who came in the second time, having lost over 50 pounds by eating just steak and eggs. He basically said, what are you worried about? And I said, well, I've talked to my doctor friends and researchers, and they said that your cholesterol will go up and you shouldn't do the diet. He looked at me and said, why don't you check it? Well, so, I guess you have to understand it. I'm a young doctor. I was about 25 years younger than I am now. And there's this older gentleman who just lost 50 pounds and probably doesn't know much about cholesterol. And here we're afraid of this one thing in the blood. And I thought, well, I'm at the VA, the Veterans Affairs clinic, and nobody pays to have their cholesterol done, or doesn't cost anyone anything. So I thought, okay, I'll send him and get his cholesterol done and get it checked, because that's what I was worried about. It was better across the board. The total cholesterol went down, the LDL went down, the triglyceride went down, and the HDL went up. So across the board, if those are the four major things, I'm going to add in a few other things by the end of the talk today. But by all accounts, the cholesterol got better, however you define it. And we're going to have to go into defining cholesterol just a little bit tonight, I'm afraid. But so the cholesterol got better. So the second person came in, so I'm like lightning struck. It's amazing. It got better. Well, the second person on a low carb diet, 1998 for me, remember this was a while back, came in, and I immediately had him go for a cholesterol level because everyone was worried about it. And again, everything was better. The total cholesterol was down, the LDL was down, the triglyceride was down, the HDL was up. So I'm thinking, if people say this can't happen, and I see it twice in a row, I'm kind of smelling a rat here. That something's not quite right about this diet and cholesterol thing. So even today, so beware, if you haven't already experienced it, there's a knee-jerk reaction that, you do a higher fat, low carb diet, necessarily your cholesterol will go up, even you shouldn't even do it. Well, I can help you with that. That shouldn't be a barrier to have you start a high-fat, low-carb diet, because I now know through the lens of 20 years that something else happens in the blood. And we'll get to that in a minute. And it's a good thing. It's just a different thing. So where did the statins come from? Where did this worry about cholesterol come from? Now, and I need to have you remember just one thing from tonight. High cholesterol is not a disease, okay? Now, as a physician, I try to prevent disease, or if you have it, I help treat it. But high cholesterol, at best, is a predictor of a disease. It's not the disease itself. And you're going to hear this all the time. It's like, it pains me to hear doctors and nurse practitioners and PAs and all the ancillary people who haven't really been taught much about cholesterol other than lower it and lower the LDL. That's kind of all they've been taught. Actually, cholesterol is not a disease. What we're trying to do with the other things that you can do to reduce your cardiovascular risk, what we're trying to do by treating or measuring cholesterol is to reduce your cardiovascular risk. So what is cardiovascular risk? Well, that's a disease of the arteries. The arteries themselves may get hardened, may get blockages, may get aneurysms or swellings like the bulging of a tire. So what we're trying to do is prevent cardiovascular disease, the arterial damage. High cholesterol is not a disease, and even then, people will get into the good and the bad cholesterol. You need cholesterol. If you are born with a genetic problem that you can't make cholesterol, you do not get through childbirth. The baby dies and aborts. It basically miscarries. So you need cholesterol. And then yet people will tell you have high cholesterol. We need to treat it with a drug. Well, so my first question now with my patients, again, this is 20 years after I first saw my patient violate all rules by lowering his cholesterol by changing the diet, so without a drug. Oh, right. So you can actually make lifestyle change and get medical outcomes. But today you have a high cholesterol and a doctor wants to put you on a medicine. So let's just think about this. So first of all, diet change itself now through the lens of 25 years, I can do more by changing the food. It's my secret weapon, really, than by using medications for just about every chronic medical condition. And I speak, I'm an associate professor of medicine at Duke University. I came from a busy clinic today. I'm in Durham, North Carolina, and you can line up in the queue to come see me, or maybe call the day before and get a cancellation, but you don't need to come see me. What I want to give you is the information so you can inform yourself about making decisions about statins, about cholesterol itself. So high cholesterol is not a disease. At best, it's a predictor of the disease. So it occurred to me rather recently, if you don't have a disease, or you don't know if you have a disease, you don't even know if you have a high risk for a disease, do you want to take a medicine for a disease that you might not have? So if you start asking the question of, well, doctor, why are you using this medicine? Well, then I'll just say, why are you using a statin? Well, it's to lower your cholesterol. No, cholesterol is not a disease. Well, then it's to lower your cardiovascular risk. Well, do I have cardiovascular disease? Now, what's fascinating is some families never get cardiovascular disease. There's a strong genetic and environmental component of factors. So if your family never gets heart disease, so how do you know if you have cardiovascular disease? If you have a family history, you maybe have the genetic background to have it happen or not, right? So in my family, it turns out that cancer is more prevalent, and people in my general, whether it's environment or genes, don't get heart disease. Now, having a clinical symptom, and I already see some clinical symptoms and diseases that or syndromes that you've had. So a TIA, or transient ischemic attack, is a threatened stroke, which is the brain losing blood flow and oxygen from the blood, so it starts to die. If part of your brain starts to die, it has trouble. You might get slurred speech. You might get paralysis or semi-paralysis of the arm or leg. And if those symptoms go away, you don't have a permanent damage to that part of the brain. That's called a TIA, or transient ischemic attack. Now, if you have chest pains, angina, which it's not pain, it's really felt more like pressure, like and at worst like an elephant sitting on your chest. Sometimes it might feel like heartburn, even burning, or sometimes you might feel jaw pain or pain going down the left arm. These are all symptoms that you might have when the coronary arteries are blocked, when you have atherosclerosis, when you have arteriosclerosis. That the disease is the artery being diseased, not the cholesterol. So remember, high cholesterol is not a disease. Now, if you had something called claudication, which means you get cramping in your calf when you walk, say 100 yards, and now that's happening to you over and over, you might have narrowing of the arteries going to the leg muscles. And if you have narrowing of the arteries, arterial disease or atherosclerosis, or narrowing there, that's the disease. And the symptom might be the cramping or pain in the leg called claudication. So again, the outcomes of narrowing of diseases, you could have something that comes and goes, temporary loss of function of an organ, and then it comes back, or you might have permanent damage to the organ. If the atherosclerosis affects these arteries in the neck, the carotids, you might have a TIA or a stroke. If the problem affects the coronary arteries, you might have a heart attack, or you might have an arrhythmia, skipped heartbeats that are out of control. If you have atherosclerosis of the aorta, the large artery in the belly, that might give you pain and problems down the legs. So again, high cholesterol is not a disease. What we're talking about is arterial sclerosis and atherosclerosis. And the first question before you take any medicine for a disease is to ask the question, do I have it, doctor? Do I have the disease? And the doctor may go, well, that's interesting. The guideline says if you have a cholesterol LDL over X, Y, or Z, you need to be on a medication. And you say, well, guidelines are kind of made for the whole population. I want to make a decision based on me. So now we're getting into the difference between general guideline medicine and personalized medicine. It takes a little more time to talk about these things, and that's probably one reason why a lot of doctors don't do it. They don't have a lot of time. But what you want is at least an ability to know if you have the disease that you're being treated for and treated to prevent. Actually, many years ago, I was at a family reunion, and my cousin, who was a top executive of a company, had an executive physical, and he had a positive treadmill test, meaning so now how do you know if you have disease of the coronary arteries? We can put you on a treadmill and monitor the heart and put a dye coloring in the vein or artery to see the arterial flow and then to see how well you can exercise. My cousin had a positive treadmill test. So what happened there is, well, we suspect you might have disease of those coronary arteries. So that he went for a heart catheterization, which is where a tube is run into the coronary artery and dye is injected, and you actually see the interior of, well, the cast, the whiteness of the interior of the arteries. Well, my cousin didn't have any arterial disease. He had what was called a false positive test. So after this was all done, they said, well, your coronary arteries are fine. We'll send you home. But you ought to do that low-fat diet to prevent heart disease. So I thought to myself, So he ought to do a diet that is to prevent a disease he doesn't have. This is madness. Oh no, it's guidelines. Guidelines. It's because just about everyone will get heart disease. No, that's not true. You can customize this and personalize this for yourself. So now let's transition over to cancer. Would you take a chemotherapy drug if you didn't know that you had cancer or not? And okay, of course not, because oncologists know, the cancer doctors know, you would never give a treatment like chemotherapy or radiation unless you had a tissue diagnosis of cancer. I remember in training, I'm a doctor now in the outpatient setting. I get to talk to a lot of people and assess risk and talk about these things. In training, I remember that there was a hard search to get tissue before any treatment for cancer would be done. A couple of reasons for that is a lot of the medicine or chemo and radiation is kind of toxic. So you don't want to give some, or surgery for that matter. You wouldn't want to take out someone's intestine under the suspicion that they have cancer without the diagnosis, the tissue biopsy, meaning it's sent out for pathology evaluation and you have it, and then they go in and give you surgery, chemotherapy, things like that. Hopefully then it's all gone. Well, in the cardiology world, the internal medicine world, family medicine, the world of cardiovascular disease, apparently, I guess it's because cardiovascular disease is so common, we just assume you have it or that you're going to get it. And now this is a function of medication care. Medical care today is basically giving medications. There's a huge underestimate, even kind of denial that lifestyle can make a difference. And I learned years ago going into obesity medicine that if I could help someone lose weight, we could fix 3 or 4 chronic medical conditions all in one fell swoop because we were treating the root cause. And so those gentlemen I saw years ago at the VA whose cholesterol got better, they weren't using a drug. They were using lifestyle change and weight loss as the treatment to improve their cholesterol risk profile. And so, back to the oncologist, it would be crazy to give chemotherapy if you didn't have a tissue diagnosis of cancer. Likewise, it's crazy to give a pill to lower cholesterol, which isn't the disease, that you don't even know if you have the disease of atherosclerosis or not. So what's happened now over the last 20 years is you can assess whether you have the disease or not. Now, your doctor might not be comfortable giving the order to do this. Your insurance company may not pay because our insurance company is and our medical care is very reactive. We don't prevent things very well in the medical world. And then if it's not a medication, well, diet side, most doctors have no training in diet and nutrition. And then this is all I do now is talk about food and how it impacts your health. So the first thing to know is high cholesterol is not a disease. Do you have the disease first? If you don't have the disease, and there are a few studies, lots of studies that have what's called primary prevention use of statin medications, meaning primary prevention means you don't have the disease yet, or actually at the time it was any clinical manifestation of the disease. And if you give a statin medicine or even other cholesterol lowering medicines, there may be a very, very small benefit for using a medication. And in most people's minds, it's not worth it. So for primary prevention, so if you don't have arterial disease, especially if you've lived to the age of 50, 60, 70, 80 without arterial disease, you don't have it. Don't take a drug to prevent it. This makes no sense, regardless of what your cholesterol level is. Cholesterol is not a disease. You want to know if you have the arterial damage. Now, if your doctor won't help you figure out, it's almost like if you bought a home, if you ask for a loan to buy your home from the bank, a loan from the bank, they're going to make you get an inspection on the house. And they don't just look at the outside, tap a few things like doctors do, and go, oh yeah, you're fine. No, you go in, you have a plumber going in, look at all the pipes, and you have an inspector that flushes the toilets and makes sure things flow. So an inspection of a home is even done into greater detail than how we inspect humans. Isn't that kind of crazy? You can get your lab test done. Doctors are very comfortable doing that. I've now, in my mind, gone beyond that. That you need to know if you have the disease, which means get tests of the arteries. They're your arteries, nobody else's. You may have to pay $150 to a company that goes around. The one that comes to our area is called Lifeline Screening. And that's what it is. It's screening. It's not the definitive test. But if the screening is positive, then you go get another test. If the screening is negative, that means you don't have the disease. You can actually have the neck artery, the belly artery measured for as little as $150, at least in my area in North Carolina. Now, you might say, well, those are parts of the arterial tree. The arterial tree starts with the heart and then goes out from there. And the coronary arteries are not really easy to measure. So this is where we get into statins don't have any risk, and we'll just give everyone, because everyone's going to get heart disease, we'll just give everyone. I've heard doctors say you should put statins in the water. And no, I don't think that's a good idea, because actually statins do have harm, and you need cholesterol. And the way statins work is that they block the production of cholesterol. I'm not going to get into that in great detail, although I do in the class I'm going to talk about in just a few minutes, that you can learn about all this detail if you want all the biochemistry. Suffice it to say, the statin medicines lower the production of cholesterol in the body. And remember, the idea is that high cholesterol is a disease, but it's not. You want to assess your arteries. Measuring the coronary arteries, you can measure the function, like get on a treadmill, have an EKG hooked up to you. And you see, you go on a treadmill, more energy than you would expend typically. So it's stressing the heart. That's why it's called a stress test. And then if there's no heart abnormality, it doesn't mean you don't have any blockage. It means you don't have any significant blockage that's limiting the function at typical exercise levels. So, it doesn't mean you don't have a narrowing and then a clot comes on. It doesn't protect you from saying you don't have risk at all, but it's useful to know. So it'd be kind of like inspecting a house and taking the sinks, all of the sinks and the toilets, and flushing them all at once to see if the flow out the pipes is clear. Not just one sink going on and on. Let's test them all to see if there's any blockage. So that's kind of like your stress test. But you can actually get studies now, tests to look at the arterial process. Atherosclerosis is actually, the healing of it uses calcium. The process uses calcium. You can get deposits of calcium on the coronary arteries. So you can get a CAT scan. It's called the coronary artery calcium test. It's a rapid CAT scan. It involves some radiation and some cost. It requires a doctor's prescription because it involves that radiation, or the CAT scans are under control of the medical system. And if you have no calcium deposition in the coronary arteries, it's good evidence that you don't have any active atherosclerosis going on in the coronary arteries. And the power of zero is the title of a series of articles out of Miami that uses the coronary artery calcium score. If your coronary artery calcium score is 0, it's a good reassurance that you're probably not going to have a heart attack in the next 10 years. Now, the risk isn't 0, but it's much lower than if you had calcium there. So having calcium in the coronary arteries means there's been some process going on and some healing, but it doesn't tell you if you have narrowing. So again, I really like the idea of treadmill tests, functional tests. If you can't get on a treadmill, you can be given a medication to speed up the heart, and you can stress the heart that way to see if the coronary arteries are allowing enough flow to go through. Now, there's another CT scan test that some people can get, some people can't. It's under the control of doctors because it's a CT scan. It's called the coronary CT angiogram. Now, in this test, it's a little more detailed than just the calcium score. And you actually can see the insides of the arteries with this angiogram because you're giving someone material to see the arteries themselves. And while it's not, widely recommended for prevention, it is available. And if you were high risk, a lot of other things pointed toward the presence of atherosclerosis, but you're not sure that you have it. You haven't had a heart attack or stroke or anything like that. You might talk to your doctor or cardiologist about getting a CTA. It's called coronary CT angiogram. The technology is there. The limitation has to do with cost and payment and risk and benefit and guidelines and population sorts of decisions. If you want personalized medicine, you need to take the matter into your own hands sometimes and ask the doctor, if you're going to give me a medicine like a statin to prevent cardiovascular disease, do I have cardiovascular disease? If you don't, the benefit of a statin is very small. In fact, most evidence-based medicine doctors and guidelines will say it's not worth it because there is a risk to the statin medicine. Now, let's say you have let's say you have the disease. Remember, the disease is arterial sclerosis or atherosclerosis. It's really the same thing, generally speaking. So you have narrowing somewhere, or it affected the brain, TIA, or a stroke, which is the permanent damage there, or it affected the heart. You had angina or a threatened heart attack, or you had a heart attack. You had claudication to the legs, or maybe even an amputation of a toe because the arterial flow was so bad. That means you have the disease. You've probably even had an angiogram or a heart catheterization or some invasive sort of test to document the presence of the disease. Now, in large studies for all of these conditions, taking a statin medicine is helpful to lower the risk of a subsequent event. And most doctors would say it's a reasonable risk reduction that you might want to consider to take a statin, and there would be some benefits from it. So in my mind, and that's called secondary prevention. So if you've already had the disease events in studies that have been done using cholesterol lowering medicine, whether it's the cholesterol or something else causing it is an open question still, it is probably beneficial. Benefits outweigh the risks. If you have had a stroke or TIA, if you've had a heart attack, or you've had narrowing of the arteries, you've had aortic problem, meaning the artery in the belly, then taking a medicine like that is probably a good idea. I mean, even in the keto world of anti-statin and statin bashers, I'm on both sides. I'm not against medicines if there's a good benefit from it. But now, again, this is sort of taking population view and guidelines. When I go over, and maybe I'll go over it in the next live if I can fit it in, is you can take your numbers, your blood tests, and your age, and whether you have these diseases, and input it into some online risk calculators to see what your risk is, and then what your risk would go down to if you took a medication treatment. So these risk calculators are widely available. I even wrote a paper on these being available, and this is a way to personalize or individualize these guidelines that have really kind of gotten out of hand. The idea that we would treat a surrogate marker of a disease rather than the disease itself. So remember, if you don't have the disease, if it doesn't run in your family, and someone wants to give you a medicine to lower a disease you don't have and you're destined to never have, this is madness. It is. But I'm traditionally trained, and I have gone through kind of the, well, it's worth it and yet I've seen in my own limited experience, someone who had such bad side effects from one of these medicines that they couldn't get out of bed. And no one suspected that the medicine was the cause, because everyone should be on it. It should be in the water, that sort of thing. So I've become one of those doctors that suspects a medicine can be the cause of just about anything. And it's clearly documented that statin medicines can cause muscle pain, muscle myopathy, even muscle breakdown, and memory loss, things like that. The mainstream folks will kind of poo-poo it to say, well, it's not much. Well, it's your decision. It's not your doctor's decision to take a medicine, and you can actually gauge the risk in a more precise way. It turns out when I put my information into a risk calculator, over the next 10 years, my risk is 2 in 100. And if I take a medicine, I can lower it to 1 in 100. If you put it in the other way, I have a 98 out of 100 chance of having no problem over the next 10 years. If I took a medicine, I could lower that to 99 out of 100. So for me, that's a risk I'm willing to take. I'm 98% chance not having a problem, but if I took a medicine, I'd have a 99% chance. So now if you get into the weeds here, the relative risk reduction there is 50%, going from 2% to 1%. And that's where a lot of naysayers and critics of the statin world have said that they've overplayed the results by using that relative risk reduction. At best is a 30% relative risk reduction, which seems like a lot, but if it's an 8% to a 6% change absolute risk reduction, that may be a decision that you decide not to take. So, if you're risk averse and you say, I want to do everything I can to not get a heart attack or stroke, and that going from 98 out of 100 to 99 out of 100 chance is worth it to me, or to you, to take a medicine, then do it. It's an individual decision. And I'm fallen out of the world of, we'll follow a guideline and just blindly give you medication. But then, of course, over the last 20 years, I've learned that lifestyle, meaning diet in my world, is so much more powerful than these medications. So now what you have to understand, high cholesterol is not a disease, and LDL is good for you. I know, and you're going to say that's just terrible. No, you need LDL. Remember, if you don't make cholesterol, you die, and actually you don't survive the fetal embryonic development. So, but even then, if you look total LDL, HDL, triglyceride, if the cholesterol went up and it was the good cholesterol, you'd say good, your HDL went up. So in my area, we're still in the other doctors are in the mindset of, if the LDL goes up a certain level, you give a pill. It's like there's no, in fact, you coerce, you use thumb screws or fear mongering to get people to take a medication. It's a little crazy, actually. And again, it's these powers that be make guidelines and make a decision for you when you should be able to make the decision for yourself. And lately, even when the HDL is over 100, which is an extremely high and protective HDL level, I've seen the doctors and in mid-level, meaning PAs, nurse practitioners, who follow guidelines, make the mistake of not looking and not valuing the HDL, not valuing the triglyceride reduction. And so now I'm entering into the new paradigm of talking about metabolic syndrome. So in the blood, I don't look at the LDL and the LDL in total much anymore, other than to reassure you. Or you might look at the small LDL and a particle determination, or the LPIR on the NMR lipoprofile seems to be the best predictor. But again, these are just predictors. Do you have the disease or not? But in the blood, I look at the triglyceride and HDL. And this is called the old way, looking at LDL, to the new way, looking at metabolic syndrome, which is triglyceride and HDL. So it's not wrong, it's just different. And in a really important study that I did a video on and will coming out very soon. It's in process. In a study out of Stanford, they basically looked at the extreme diets and ultra low fat, ultra low carb. They both reduced insulin resistance. One of them did it with LDL reduction. One of them did it with a triglyceride reduction and HDL elevation. They both worked. It's like driving on the left-hand side of the road and the right-hand side of the road. Now, you don't want to do that in the same country, but they can work. They're different rules. And so both these ultra low fat and ultra low carb diets actually work. And this study that just came out was a randomized trial sub-analysis, meaning a secondary analysis. And it's very interesting to look at these two subgroups. So we look at triglyceride and HDL in the keto world and downplay or minimize the old total cholesterol and LDL, while I know other doctors overvalue that. And actually, but it's kind of ridiculous. What was my saying? It's madness that you might go. So this is a story I heard in my patients recently. I lost 100 pounds. I went in. I came off all my diabetes medicines. My A1C went from 14 to 5.5, which is normal, off medicines. And this is by losing weight, by changing the lifestyle, really just diet in our program. And my doctor looked at me and said, yeah, but your LDL went up. I need to put you on a statin. I'm like, no, don't. So among my patients, and if you're one of my patients, if someone wants to give you a medicine, yeah, let's talk about it. Not for infection or something like that. That's great. But for a chronic condition that you're not even sure that you have yet, and remember, you can't tell if the pipes are clogged at the house unless you go in and check them out. Having gone through home purchases, the bank's not going to let you get a loan unless you have it checked out. So, it's almost as if you might make the decision to just buy the house sight unseen and not inspect it, but the bank's not going to let you get a loan without it. So, I know often we underestimate our own value, our own worth, but you can get these arteries measured, and that's the disease we're trying to prevent. High cholesterol is not a disease. At best, it's a predictor, and it really is upon ourselves now to measure our own bodies and get it measured. And so my patients will come in, every couple of years getting these ultrasound tests and the coronary score every couple of years. And I taught people to do that because, remember, everyone thought 20 years ago that this would necessarily, that a low carb, high fat diet would always cause heart disease and kill you. I mean, and in fact, it was so certain that no one would study it. I only learned this after years of being in here and talking to these other doctors and other scientists. They said, well, how could we study a low carb diet? What would we do? Raise the fat, the fat in the food. So, now I can say, eat more fat, and it's fine. I don't have to stutter when I say it. So again, it's just using a different method. Cholesterol is not a disease, and know if you have the arterial disease or not. So I'll be interested, give me some comments, give me some Q&A about this. And what I'd like to do is just tell you just a little bit about the cholesterol course at Adapt Your Life Academy. The reason I'm professing about this, I am a professor at Duke, is that I wrote a course. One way to really know something is to write it. Not just to speak about it, but to actually write it. So I wrote a course at Adapt Your Life Academy, and it's open enrollment right now through August 7th. I want to tell you just a little bit about the course. It's a self-paced online video-based training program with me giving the videos designed to help you understand the facts about cholesterol and cardiovascular disease so you can reduce your risk and be more informed and confident in your own healthcare. So I have a module on how to talk to your doctor about this, because a lot of doctors just don't know how to have a conversation. They kind of turn you off. And I've had patients be fired from their doctor. Did you know you can fire a patient? I didn't know that. But the doctor fired them because they wouldn't take a medication that they were advising. I mean, I learned a long time ago that I'm an advisor. I don't dictate what people do. And what's crazy is that when you survey people, a lot of people aren't taking the medicines that the doctors are prescribing, yet the doctors kind of ignorantly believe they do. But so in this course, I go in depth about things that you need to know, like cholesterol is important and how it affects your body. And there's really no such thing as bad cholesterol. And I try to make it so clear that I have a mock courtroom scene where we go through this and with judge-like precision and accuracy. Well, we put cholesterol on trial for heart disease, and it's an interesting test to see if there's enough evidence to implicate cholesterol. You'll learn about the role of cholesterol in cardiovascular disease. Yes, it's in the arterial lesion, but that doesn't mean that's the cause. If the kitty's up the tree and I have a ladder and take it down, it doesn't mean the kitty got up there by my ladder. So we now believe that it's inflammation that sets the stage, like a sunburn. This sets the stage for the infiltration of the damaging things into the arteries. In the course, you'll learn how to assess and treat cardiovascular risk through lifestyle change, talk about other things like insulin resistance, if you've heard of that, carbohydrate intolerance, how to measure those things. I try to make this in a way that you, as a layperson, not medically trained, can understand. Although there are some graphs and figures, I do pull out some of the pivotal trials, randomized trials about cholesterol. So if you are medically trained, this course will give you the background to really understand how we got into this mess, the relative risk, absolute risk reductions. I have it all in there as well. So the course is available now for signing up at my company, which is called AdaptYourLifeAcademy.com. So if you have interest, just go check it out, AdaptYourLifeAcademy.com. Now, let's see. I'm showing this. There we go. I'll just have that on the ticker as we go. Again, thanks for tuning in live or on the replay. And let's see if we have any questions. Thank you. Lisa Becker is on the line here and will be helping to add advice and detail. She's one of the team leads at Adapt Your Life Academy. But if it's a cholesterol question, then that's for me. So hi from Singapore, fantastic. New York. Let's see, some questions. My problem with statins is night leg cramping. Seems like I am just likely to die of lack of sleep. Well, so Bill, of course. So are you using a statin to treat a disease that you have? That would be the first question. That puts you into primary or secondary prevention. And now there's sort of a gray area. If you get a test that's positive, but you have no symptoms of it, this is kind of nobody really knows how to handle some of the information that you can get today. But I would have a discussion with the doctor who prescribes your statin that, maybe if you do need one, you could find a different type of medicine. Again, if you have evidence of the atherosclerosis. So yeah, thanks, Tracy. The Mayo Clinic Statin Decision Aid is a online tool, Mayo Clinic Statin Decision Aid, and you can put in your information there. They have several guidelines that they follow, an algorithm to kind of spit out your risk in graphical form, and then your risk if you took a medicine. Now, I just have to say that these studies with medications are among people who eat carbs. So let's say you're in the low carb keto world and you put in your data at that website, it's giving you the risk that would have happened had you been a carb eater, because that's how people ate pretty much in all of these studies. I don't know that it means it doesn't apply. I'm hopeful, and we have other studies that are brewing about cholesterol if you eat a low carb diet, that I'm hopeful that we can even do better than those kinds of guidelines. So JMK2921 says, my cardiology wanted to get my LDL down to 20. I refused. He said he didn't need to see me again. Well, Yeah, classic, right? Well, medical care today seems it's medication care, you know? Now, cardiologists have bought into most of them have bought into the idea of LDL reduction. And, as a diplomatic former president of a medical organization, what I will say is that that's one way to do it. Now, there are side effects, and they have very small studies showing some benefit. But one of the things that made no sense to me, and looking back is really pretty crazy, is they allow now medicines to be FDA approved just by showing it can lower cholesterol levels. So you don't have to even prove that you've reduced events, because again, they've moved the bar so away from if this is the, I guess, the touchdown or the field, and here's the goalpost, you don't even have to show that these medicines reduce events anymore. You can just show it reduces cholesterol. And that's kind of sad, because high cholesterol is not a disease. Yeah, but that's just how they're taught now, let's see. I see someone's trying to fix your cramp. Well, having dealt with people who get leg cramps, because any effective weight loss program has, maybe 20% can have leg cramps during the first few months. A swig of mustard or pickle juice works like a charm. So, Bill, maybe in the next few minutes, if you can get a swig of mustard or pickle juice, let us know if that happens. Let's see. Statins make your life miserable. Well, they can have side effects. Yeah. Let's see. So I hope you're seeing now that it's impossible for me to advise you based on one number. I need to know if you have the disease. It's impossible for me to say, don't take this medicine because you don't have the disease, because I don't know if you've had those tests. I don't know if you have the disease. So let me put it a different way. If you've had a heart attack, you've had a stroke, or a threatened heart attack, or a threatened stroke, you've had a stent, that means you've had narrowing. If you don't have a reason not to be on a statin, like a major side effect or something, I would use one. I would say, there are a lot of unknowns, but the studies are pretty good to say if you've had the disease process going on, take a medicine to lower it even more. But then, doing a low carb, high fat diet actually lowers inflammation as well. We think that the statins actually work by lowering inflammation as opposed to lowering the cholesterol level, but most people focus on that cholesterol. So, I really can't comment on your specific case just on one number. Let's see. Good. Well, other questions? Thanks for the comments, of course. If you've had quintuple bypass, which is, I assume that's the coronary artery bypass. So in my weight loss world, someone says bypass, they mean gastric bypass. That's a weight loss surgery, actually. So if you've had narrowing of the arteries, if you have 3 arteries involved, or the main one, they will bypass, have an open heart surgery and bypass the arteries. And those seem to be folks who get that have the best outcomes over time. Great. Thanks for, let's see. Doctor says the studies show that statins make the plaque more stable. Well, that may be. And again, you're assuming there's a plaque. So if you have plaque, that means you have the disease, and the medicine might help in preventing progression of the disease. If you don't have the disease, there's no need, or it's madness to be on a medicine for a disease you don't have. Let's see. I don't know, Wilma, if keto helps hypereosinophilic syndrome. I don't know. And things that I don't know about, if I see someone in my clinic, I do a full history and physical. This internet medicine thing, be careful. I'll have people fill in forms and talk to people on the internet. And then when I see them face to face, I learn things that I didn't know, that, medical conditions that they didn't tell me about. because, well, I didn't know it was important. So anyway, if you have a disease like that, what I would do is come in, be a doctor, talk to you, have you do a keto diet, monitoring whatever the disease is, whatever the condition is. And if there's any, so I don't think there's any reason you can't do a keto diet. We would monitor you. And so in the context of medical monitoring by someone who knows about how effective a lifestyle change can be, I would think it'd be worth a try to help that syndrome. Often I learn about syndromes because I use this approach for weight loss, and the other syndrome gets better. So actually I've learned and helped to stimulate the growth of mental health treatment for using a keto diet, because one of my patients came in, and 8 days after starting the diet, she told me that her schizophrenic voices were gone. And I looked in my clinic notes, it's back when we used paper charts, and I didn't even write down that she had schizophrenia, because there were so many medical issues. But it turns out that person for years, decade, had no longer had any symptoms. And now there are 2 metabolic psychiatry units, one at Harvard, one at Stanford, that are using keto diets in research and in clinical care, in part because I used this approach to help someone lose weight, but the other disease also improved. I didn't know that it would have that kind of effect. Yeah, so Kathy says, I just don't eat sugar and highly processed foods. Exactly. I mean, this is a keto diet, a properly formulated vegetarian diet. Doesn't matter really to me where you get your nutrition. If it keeps the sugar down really low, it means it keeps the insulin low. And remember, starches get digested to sugar. So I think the mainstream is saying, yeah, sugar and highly processed food is the bad element in our diet that we need to restrict for health. Let's see. Other questions. Calcium score of 27, a reason to take a statin. Well, Joe, I don't think that's enough information. So a calcium score of 27 doesn't tell you if you have narrowing or blockage. And if that's a discussion. If you can get the other arteries checked, if you had disease in these other arteries and a calcium score of 27, you might want to take a statin. But if you didn't have disease anywhere else, you might consider a treadmill test or a coronary CT angiogram to get more detail about that. So the calcium score is a bit of a Pandora's box, because if it's not 0, it means you've had some disease, but it doesn't tell you how much disease there was or there is. So it doesn't, although it got popularized because it saved a prominent man's life, because he didn't know that he had blockage on what's called the left main artery. If the left main artery blocks, it's called the widowmaker, because you basically, if you don't get blood flow to the entire heart, it stops, and there's very little you can do to get the flow back there. So it's called the widowmaker. So it was popularized in a movie and put into books that if you had a calcium score of 27 and the location of it, so now you get into where is the calcium. If the location is right where the left main is, it might be a different issue. And so on the reports that you get, it does say where. Some reports even kind of put in little marks where the calcium is. So that's a decision that you would want to discuss with an expert, no question. Of course, you go to a cardiologist, they'll probably say they'll put you on a statin anyway. I mean, but again, high cholesterol is not a disease. And even then, the calcium score does not tell you really the extent of the disease, unless it's 0. And then that's a good predictor that you don't have disease. And even then, it's in the Mesa Study, it's called MESA, they took people and followed them over time to see if they lived and died. So it was an outcome study that if you had a coronary score of 0 on a calcium score, it was a good prognosis, a good sign for you. Let's see. Thanks for the positive comments. Mike says, my wife had a heart attack, got a stent, is now home, but it's very weak. The doctor wants her LDL to be 55. how can I convince her that that's a bad idea? Well, so Mike, I'm not sure it's a bad idea. So depending on the extent of the disease and what other options you have, if there's obesity, if there's insulin resistance, if there's type 2 diabetes, those will be more important actually to focus on than just an LDL. That's another mistake I think cardiologists make, is that they'll just kind of forget the idea that you have diabetes and you're on insulin and you're 100 pounds overweight, and they'll focus on putting you on a statin drug. When if I get you to lose 100 pounds, take you off all of your type 2 diabetes medicine, and I don't care what the LDL is, because the risk that comes from the diabetes is 15 times, 12 times greater than mucking with an LDL cholesterol. And so there's a kind of a focus on, if it's a hammer, if it's a nail and I have a hammer, I'm going to just give it without regard to the other things going on. I get into the course in a big way to talk about the other elements that often are missed. And this is from the obesity medicine standpoint, where we reverse type 2 diabetes, we reverse metabolic syndrome with different lifestyle, even medications, and the course will teach you about the metabolic syndrome and the new way to look at the blood, which is triglyceride and HDL. The other elements of metabolic syndrome are the blood glucose, blood sugar, the blood pressure, and the abdominal circumference. If you have obesity, that's as much of a risk as a cholesterol level. So I hope one day it will be thought of as poor form to not help someone lose weight. Oh, let me put it another way. It'll be poor form to put someone on a cholesterol medicine to lower the LDL without helping someone to lose weight. So it's a mismatch in prioritization. The weight loss should come first. The elimination of insulin resistance and type 2 diabetes is a more potent thing to do. Let's see. Why do other organizations still push low carb, low saturated fat diets when neither cause heart disease? Well, JMK 2921. If you founded an organization on a low fat diet, like the American Heart Association, you will always believe in low fat diets. They won't change. If you create a church believing in Jesus Christ, and you now go in and say, I don't believe in Jesus, you're not welcome there. I guess I kind of believe there are other ways to get to heaven than just one religion. There are other ways to lower your metabolic risk than a low-fat diet. And the low-fat diet can work. And you're right, I don't believe that cholesterol and saturated fat are in that pathogenesis, that in that process, mechanistic process. But there are a lot of people that still do. Let's see. Bill says, I had a doctor who would talk about insurance companies being involved in treatment. Oh, yeah. Oh, well, I think that's pretty common. Let's see. I paid for my own calcium score, wait for the results. Yeah. So in my area, I paid for my own calcium score. I think it was $150. I needed a doctor's prescription and got one. Let's see. Ask for a CAC. Yeah, that's it. And great. Well, other questions? I'm coming on an hour. Remember, there's an open door now to get involved in a cholesterol class. If this intrigues you, if you want to learn more, I put together a class with hours of videos and the handouts, the transcripts, and we're trying, whatever way you learn best, either video or written. And we have lives during the 2-3 weeks the class is open. You can ask us during that time any questions that you want. We really try to make it interactive as much as possible. And I've learned a lot by doing the cholesterol course and having people take it, and that's I guess I've learned, like those 2 patients who did the Atkins diet, and when I was a doctor at the VA in Durham, I learned that. Remember, I learned from my patients, and so I'm learning from my patients all the time. I can't read everything and can't be aware of everything, and So anyway, if this intrigues you, you might check out the class, or at least go to adaptyourlifeacademy.com, which is going around the screen now, and see what the class is, what it involves. And let's see. Oh, I think someone's joking about coming to Durham. Well, I have people fly in to RDU and then fly out that same day. It's not hard to get to, although my office might be 20 minutes from the airport. And okay, focusing on lower HDL and raising LDL, which is, if you really want to look at LDL in greater detail, you get the lipid subfractionation. But I've kind of, again, fallen out of that world. Let's see, my cardiologist told me any statin side effects were nocebo, meaning all in your head. Well, I took a statin and it had many side effects. The side effects are real. Yeah, Rob, that's well said. And no, there's some suspicion, Rob, that the side effects were minimized or even fraudulently left out of the early studies on the cholesterol medicine treatments. I don't get into those weeds. I just try to interpret the science and the primary, secondary prevention, and actually still in the mainstream of a group within the mainstream medicine. That's called the Society of General Internal Medicine and Evidence-Based Medicine. Let's see. Thanks for the comments. My cardio wine boy says, with an H, my cardio won't look at triglycerides. Yeah, well, that's the way they're taught. I mean, if you really want to be cheeky, there are things you can say like, doctor, do you still use a phone with a cord? Well, that's not a good one because in my office, I still have a phone with a cord, but I use a cell phone. But, do you use a flip phone or, it's the new science of nutritional ketosis. And yeah, I'm working on the teaching of nutritional ketosis. It turns out that everyone goes into nutritional ketosis if you don't eat for 2 days. If you don't eat if the staunchest anti-keto people went on a place somewhere where they couldn't eat for 2 days, they will be in nutritional ketosis because we store fat on our bodies. It's normal to be in ketosis. And it's so terrible. It's normal. So again, that's in my world of seeing this from this vantage point for over 20 years. And now the corollary of that is if you don't eat carbs for 2 days, you'll be in nutritional ketosis because it's the carbs that interfere with the fat burning, not the protein itself. Let's see, other questions. Thanks for your comments. Sorry, I can't comment and call out everybody's. So Anne says, so if a person has no heart disease, do we really need to follow LDL cholesterol? Doesn't it just muddy the water? Seems we should check triglyceride and HDL. Yeah, I think that's a logical conclusion. But Anne, how do you really know you don't have heart disease, right? So often we're left with, the house is on a beautiful street and all the houses are nice and all, but there's a blockage in the artery the plummet. So if you've never had any sort of testing done, so a clinical symptom like waiting for a chest pain or waiting for some sort of signal that there's a heart problem can be often too late. And that's a legitimate argument for prevention of this and using a pill or lifestyle prevention of this. So you'd really want to do your due diligence to make sure you don't have the disease. And if it's not in your family, but based on the latest prospective research on risk factors, you're right. You would want to, it's more powerful to look at triglyceride and HDL in the context of metabolic syndrome than it is to look at LDL. So you might just, some years from now, we might not even be, cardiologists will always be looking at LDL. Their field is based on it, unless some huge, enormous study comes out. Let's see. I disagree, Jeff M. High fat, not good for you. You're in the church. If you're in my office, you'll see the low fat diet up on the wall, And you can say it doesn't work and it's bad for you, but it's just not true. So you got to follow the science. Let's see. Food is medicine. Well, good food is medicine. And this is, I guess I'm going to end on this. It's a comment that a friend or colleague out at San Francisco says. Just want to make sure there's no pressing question there. Great. Well, here's a complicated one. So Gina says, my triglycerides showed 400, coronary score of 152, been doing carnivore for 54 days. Doc, 2 months. That's a good start. Doc put me on Zetia, but I stopped taking it and hoping the diet will help. Any comments? Well, so again, you don't know if you have narrowing of the disease. The coronary score doesn't tell you about narrowing. And triglycerides will probably come down when you cut carbs. I assume you were eating carbs before. That'll only take a couple months. And you want to do is follow the HDL as well. And the coronary score of 152 is really, it's in a gray area. It doesn't mean you don't have, it means something happened in there and you may have healed it all, or you might have a significant blockage there. So symptoms matter. If you're ignoring a heartburn, for example, thinking it's your stomach and it's actually your heart. So there's a lot of nuance that goes into this. You want to talk to a doctor who's been in practice for a while, who's heard lots of different stories about heart disease and how it can present. But I think it's a gray area of whether you have a calcium score that's elevated and whether you should be on a pill like that. No one really knows for sure. And doing a carnivore diet, which is a subtype of a low carb keto diet, is going to be very powerful to change that metabolic profile into no or very little metabolic syndrome, where that may have been the culprit in the first place. So it'll be interesting to see how this all plays out down the road. Okay, one last. So Kim says, would like to know your opinion on a small particle test of 3,000. So you can get a lipid subfractionation, and that's high. I would say that's high out of the normal range, and that's thought to be bad. My HDL is 58, and my triglyceride is 90. So the ratio there, your triglyceride is a little higher than the HDL, maybe 1.5. That's a good ratio. Ideally, it's 1-to-1. So if your HDL was 90, I'd be even happier. I lost 45 pounds on keto, and I'm in great shape at 65. No other issues. Well, so remember, we don't know if you have atherosclerosis or not. You want to, have someone talk to you about symptoms, maybe get some testing done to see if the ultrasound has no X-ray risk to it. That's why I like that one to start with. I don't know that I would do anything. No, I wouldn't do anything different based on a small particle test of 3,000. What you want to do on that test is look at the number that goes along with LP-IR. And it comes on most of them. What it is a summary score of insulin resistance based on all the different factors that they've measured. And that's the most powerful, good predictor in these in the clinical study that looks at people over time and as a predictor. But remember, high cholesterol, even a high small particle test, is not a disease. It's atherosclerosis. That's the disease that we're trying to prevent, trying to get you not to have. Well, that about does it. Remember, if you have any interest in learning more about this, check out adaptyourlifeacademy.com, where it says end your cholesterol confusion. Sorry, that's my diet book. End your carb confusion. End your cholesterol confusion is a course that will take you through why you need cholesterol, why you want to be careful and know about the risks that any cholesterol lowering medication might have. And it's not a one size fits all sort of deal. You can actually customize it. And I take you through the online risk calculators, talk about how to talk to your doctor, open the conversation about it in this way. Again, I hope this is good information for you. It's been my pleasure to be with you tonight, or to be with you on the replay. And if you want more information, just check out the adaptyourlifeacademy.com. And if you're one of my patients, I'll see you back in the clinic. And no, I'm not on TV. This is people will come in now and say, I saw you on. No, that was YouTube. That was just on your large TV screen. Okay. So yes, someone recently said, I just wanted to come in to make sure you were real. Yeah, here I am. So trying to get information to as many people as possible so you don't have to make the trip to Duke and Durham, North Carolina. Well, until the next time, have a great night.